A 24-year-old man, active and asymptomatic. He's had a murmur for a long time. He has bounding carotids, a 2/6 systolic ejection murmur with an early peak, and a 3/6 long diastolic decrescendo murmur. His LV is dilated with an EF of 59%. He has a bicuspid aortic valve, a mean gradient of 12, and severe aortic regurgitation. His left ventricular diastolic dimension is 64 and systolic dimension is 44. What should you do? Replace his valve, cath him and do an aortic root shot, give him nifedipine and follow up, or just follow up. Okay. 44-year-old woman with palpitations for 2 years but good exercise capacity, had 2,000 PACs on her Holter. JVP is normal, carotid is normal, LV is not displaced, multiple mid-systolic clicks, a 2/6 late systolic murmur. Her end diastolic dimension is 48, her end systolic dimension is 22, her EF is 66%. She has bileaflet mitral valve prolapse with a late systolic jet and an ERO of 0.5. What do you do? Mitral valve repair, catheter, put her on vasodilators, or reassure her. Okay. And a 55-year-old man who's completely asymptomatic with low volume carotids, a 3/6 holosystolic murmur with an early diastolic filling sound, has a dilated LV with an EF of 58, 61 in diastole, 41 in systole, those are the chamber sizes, a flail posterior leaflet with severe MR, and an ERO of 0.6. Should we mitral valve repair, cath, vasodilate, or follow? Okay. Let's see if you can make those any better.
Okay. All right. This is going to be another whirlwind. We've got a lot to do. We've got to go over the pathophysiology presentation and testing of mitral regurg. We've got to talk about timing and type of intervention for mitral regurg. We've got to look at the pathophysiology presentation and testing on aortic regurg. We've got to figure out when to operate in aortic regurg. And then we've got to say a few words about tricuspid regurgitation because it's an ever-growing problem in patients with valvular heart disease. Now, in addition to doing all of that, we also have to break valve lesions down into acute and chronic because there's a difference in the way you treat acute and chronic. So what I want to start with is to show you this case right here of a 74-year-old man who presents with acute dyspnea and orthopnea, hypotensive tachycardia, just a sick bugger in the ICU. Not much of a murmur, TTE, hyperdynamic LV, and has this type of a chest x-ray. Okay, now Nandan went through this, but if you have a patient who's crumping, who's got a hyperdynamic left ventricle, who's got severe heart failure, you're thinking what? What you're thinking is the fact that you're going to be fooled with the TTE and no murmur, and this person has severe acute mitral regurgitation. And your diagnosis has to be based upon the clinical presentation, giving you a high index of suspicion. So acute mitral regurgitation, etiology is chordal rupture, infective endocarditis, ischemic heart disease. It's got the severe heart failure. You see a S4 or S3, but the murmur may be soft, short, and many times absent. When we looked at our papillary muscle ruptures, 50% of them had no murmur whatsoever that you could hear. And the reason for that is as opposed to chronic mitral regurgitation where you've got this large gradient between the LV and aorta which causes the murmur and the turbulence, in acute mitral regurgitation your V wave gets so high that you've got very little driving pressure going backwards. And your murmur can be soft or absent in severe acute mitral regurgitation. So it's the clinical suspicion that puts you in. Remember, you treat with vasodilators, intra-aortic balloon pump, and the etiology dictates when you do surgery. If it's papillary muscle rupture, you operate now. If it's a dehisced mitral prosthesis, you operate now. If it's endocarditis, if they have heart failure, you operate now. If it's chordal rupture, it depends on response to therapy, but you're probably going to operate fairly soon. But if you have acute, severe mitral regurgitation due to a damage in the mitral valve apparatus and it's causing severe heart failure, you go in and operate. So if your echo is negative, you got to go on because you might not see the color due to the acoustic shadowing, get TEE or cath, but remember that in patients with severe acute pulmonary edema and normal left ventricular function, think severe mitral regurgitation. Okay? It'll come up again and again. Now, let's turn to chronic mitral regurgitation. And again, with the regurgitant lesions, as with the stenotic lesions, we're going to go over the etiology, pathophysiology, clinical presentation, testing, and then what's of critical importance here is the natural history of regurgitant lesions, because that will dictate treatment of these lesions. Etiology of mitral regurgitation is actually quite complicated, and what we prefer to do now that you'll see the wording come out is to categorize them into what's called primary, which means a problem with the valve itself, versus secondary, which means a problem with the ventricle. So mitral regurgitation can either be due to the valve itself, primary, or the ventricle, which is secondary. The primary mitral regurgitation, the most common is the degenerative, the myxomatous mitral valve chordal rupture. Rheumatic probably comes second. But if you think about secondary mitral regurgitation, which we're seeing more and more of it can be either due to a dilated cardiomyopathy or an ischemic cardiomyopathy with papillary muscle dysfunction. But remember, primary versus secondary mitral regurgitation because the treatment is different for both. If we think about the etiology of mitral regurgitation in 2014, degenerative mitral valve disease still is the most common cause of severe mitral regurgitation requiring operation. So etiology, think of acute, think of chronic, think of primary, think of secondary. Now the pathophysiology of regurgitant lesions, we're going to take some time on. The reason we had the talk the first night to talk about the effect of loading conditions on the heart on myocardial performance is specifically because you need to know this to understand the pathophysiology of regurgitant lesions and thus understand timing of operation. But if you think of mitral regurgitation, it's a pure volume overload, so the preload is increased. In mitral regurgitation, because you're ejecting into a low impedance left atrium, the afterload is decreased. Now, if you think back to our Starling curves and our force tension curve, preload increase is going to make the ejection fraction increase. Afterload decrease is going to make the ejection fraction increase. So if you replace the valve or repair the valve, the ejection fraction is always going to fall after operation. This is opposed to aortic regurgitation, and we'll go into the second half of this talk. But remember, in mitral regurgitation, the preload is up, the afterload is down, so the ejection fraction is going to decrease after operation. Preload up, afterload down, ejection fraction is going to decrease. Now, regurgitant lesions pose a problem. The reason that they pose a problem is because long-standing volume overload can cause incipient left ventricular dysfunction. And by the time symptoms develop, left ventricular dysfunction may have already occurred. And you know, in any disease of the heart, once left ventricular dysfunction occurs, there's a problem. So this conceptual framework on the natural history of volume overload is this, is you're going to get the onset of severe regurgitation. Survival is going to be on this axis here. You're going to go years and years and years, and you're going to have progressive left ventricular dilatation to compensate for the volume overload over the years, over the years, over the years. At some point in time, you're going to develop left ventricular dysfunction, which means that your prognosis will start to go down, and it's probably after left ventricular dysfunction occurs that symptoms will occur. So you can see right now that if we're going to just wait for symptoms, we're going to be too late. So this is the conceptual framework on the problem that we have with timing of operation and volume overload. Because once there's left ventricular dysfunction, the prognosis is poorer with or without operation. That's the pathophysiology and also the natural history. Now, clinical presentation of mitral regurgitation, remember they may have a prolonged asymptomatic interval. When they do have symptoms, it'll be low output because the blood's going backwards, as well as pulmonary congestive symptoms. Kyle went over a beautiful online analysis of the physical findings in mitral regurgitation. But remember, if it's truly severe, you're going to have a loud holosystolic murmur. And some of our mitral valve prolapse who only have late systolic murmur, they don't have severe mitral regurgitation. They still have intact chordae. They may have prolapse and they may have a late systolic murmur, but it's not severe mitral regurgitation. Severe mitral regurgitation means a disruption of the mitral valve, so it's going to be a loud holosystolic murmur. And the thing that'll tell you for sure that it's severe is you hear this early diastolic filling sound from the blood, a lot of blood going back from left atrium, back now from left atrium across the valve into left ventricle during early diastole. But remember, a holosystolic murmur, especially in mitral valve prolapse, you need to hear for severe. If it's only a late systolic murmur, it's not really severe. Now, testing, there's an awful lot of literature out there about what you need to look for in echocardiography, and they have all these type of things about strains, stress patterns, DTI, pulmonary vein, ERO, ETOs, all of that sort of thing. But there's only a few things that you really need to be concerned about. So what I'm going to try to do is simplify a world of literature into a few things that you need to know how to manage the patient. So what you need to know from echocardiography is, number one, how does it affect the heart or the left ventricle? Number two, what causes it? And number three is how much is there? Everything else is irrelevant when it comes to your clinical management of the patient. The status of the left ventricle, despite the fact that the ASE likes you to do volumes, is mainly your dimensions, because your dimensions are going to be the most accurate way to detect changes. You can use a 2D directed M mode, or you can use the 2D itself in still frames, but get accurate LV diastolic dimensions and LV systolic dimensions. That's going to be the most important thing to get. In terms of what causes it, remember that in degenerative mitral valve disease, so for instance, you've got prolapse here of the posterior leaflet, the jet will go away from the leaflet. In patients who have annular dilatation, there'll be a central jet of mitral regurgitation, also seen in rheumatic disease. And in patients who have ischemic disease, in which there's retraction and tenting of the posterior leaflet, there'll be a jet that hugs posteriorly. So the jet itself, as well as the morphology of the valve, will tell you the etiology of the regurgitation, which is going to be very important in distinguishing primary versus secondary and what to do with the patient. Then the third thing you have to know is that if in fact you do have severe mitral regurgitation, is it repairable? And I'm speaking mainly of the degenerative mitral valve leaflets, the mitral valve prolapse, the chordal rupture. Remember that those with a posterior flail should be easily repaired, and you want to make sure there's no calcium in the leaflet or calcium in the annulus. So what you want to know is you want to know the status of the left ventricle, get your diastolic dimension, get your systolic dimension. You want to know the etiology of the regurgitation, so look at the valve morphology and look at the way the colored jet is. And then finally, you want to know if the valve is repairable, and you look at what valve is affected and whether or not there's calcium or lack of calcium. So that's your echo assessment. Now, the final thing you want to know is how much is there? And in the past, everybody's looked at the color jet, you know, how much color goes back into the left atrium from the left ventricle, and they would grade it 1, 2, 3, 4. But remember that the jet area is inaccurate and misleading, because you can have very small, thin, eccentric jets that have severe mitral regurgitation. You can have very large central jets and annular dilatation flooding the whole left atrium, which can only be mild mitral regurgitation. So what you have to do is go one step further. And Sunil this evening is going to go over the measurement using the proximal isovelocity surface area, PISA. but it's a wonderful method to quantitate mitral regurgitation, and you will get numbers such as effective orifice area and regurgitant volume and regurgitant fraction, and I would urge all of you to follow this, to get this done in your laboratories so that you will have a quantitative measurement of the degree of regurgitation. But also remember that your measurements have to correlate with your clinical findings. So beware of the jet area, because that may not give you exactly how much mitral regurgitation there is. One number to remember is that if your effective orifice area, which is essentially how big the orifice is greater than 0.4 centimeters squared, it's probably severe mitral regurgitation. But be careful in the late systolic prolapse, because in the late systolic prolapse, your effective orifice area is not going to be accurate, because the effective orifice area assumes that regurgitation occurs throughout all of systole. And in late systolic prolapse, your effective orifice area can overestimate severity. So use effective orifice area, do it whenever you can with mitral regurgitation, but be careful that if the regurgitation is not holosystolic, you can overestimate it. So echo flow alone, remember, underestimate, overestimate, and if there's any discrepancy at all in the severity of regurgitation, when you're correlating it with your clinical examination, go ahead to cardiac catheterization and get a good left ventriculogram. Left ventriculograms themselves, you know, have problems, but they will help you if you're on the fence, if your clinical examination doesn't necessarily match your severity of regurgitation by echocardiography. So board tidbits, remember the wide eccentric jets are usually severe, the central jets are usually not severe, and if you have something like mitral valve prolapse with a late systolic murmur, the ERO may overestimate severity. And a nice practical thing is to look at the size of the left ventricle and regurgitant lesions. Because if you truly have severe regurgitation, the left ventricle cannot be normal size. If you truly have severe regurgitation, the left ventricle will not be normal size. Something to remember. Okay, so in patients with clinical signs of severe mitral regurgitation and only mild MR by TTE, you should go further. You may be underestimating it because of the problems with acoustic shadowing from calcification or the jet going back into the left atrium, and then you either get a TEE or get your left ventriculogram. So that's etiology, pathophysiology, clinical presentation, and testing. Now we go back to the natural history of mitral regurgitation. Now overall, if mitral regurgitation is truly severe, it has a poor prognosis if left untreated. At the end of 10 years, 6 out of 10 will have developed heart failure, 8 out of 10 will have required surgery, and 9 out of 10 will either have required surgery or died. So if you have severe mitral regurgitation, the prognosis is poor. And we can use things like effective orifice area to tell us even more about prognosis, because we know that the larger the effective orifice area, the poorer the survival. And again, we're going to use this cutoff of 40 millimeters squared as severe mitral regurgitation. Now treatment. Again, when we talk about valve lesions, we should go back and we should look and see if there's any medical treatment. And despite the fact that you would theoretically think that vasodilator therapy would reduce the severity of mitral regurgitation, in the absence of systemic hypertension, there is no indication for vasodilator therapy in the asymptomatic patient with preserved left ventricular function. There's been many studies done that have shown no benefit of vasodilator therapy if you're asymptomatic and you have preserved systolic function. Now, if you go to the guidelines, you're going to see a whole lot of indications for operation. And to try to stuff these all in your head, when you also have to learn congenital disease, pulmonary hypertension, vascular disease, arrhythmias, is going to be impossible. So what we're going to do is we're going to make this simple for you in terms of timing operation for mitral regurgitation. And instead of that mass of indications in the valve guidelines, remember this. We're going to look at symptoms, number 1. We're going to look at the status of the left ventricle, number 2. And we're going to say a few words about prophylactic surgery, number 3. So instead of that huge, massive guideline indications, think if the patient is symptomatic, look at their left ventricle, and figure out whether or not you might want to do a prophylactic operation. So, indication for operation in mitral regurgitation, if it's primary mitral regurgitation, any symptoms. Mild, moderate, severe, any symptoms, unless it's prohibitive, in which case your ejection fraction might be less than 25% or a lot of comorbidities. But even mild symptoms with severe mitral regurgitation, if they're operative candidates, you're going to operate. So class 2, class 3, class 4. The second thing I said is after symptoms, if they're asymptomatic, look at the status of the left ventricle. And you want to operate if there's left ventricular dysfunction. But what is left ventricular dysfunction in mitral regurgitation? Now remember, mitral regurgitation has that low impedance leak. There's a volume overload. Because of that, your ejection fraction goes up, your end diastolic volume goes up. So you've got to decide when severe mitral regurgitation is producing left ventricular systolic dysfunction. And again, we're going to go over some of the natural history studies. This is from Maurice Serrano at our institution that looked, but look at this. Any patient with an ejection fraction less than 60% has a poor survival postoperatively. Now in coronary disease, we use 50 to 55% as normal. But remember, mitral regurgitation is going to increase your ejection fraction because your preload is increased, your afterload is decreased. So we're going to go up to 60%, and any ejection fraction less than 60% is considered left ventricular dysfunction. The other measurement, that's a wonderful measurement to use, is the end systolic dimension. And this goes back to your pressure volume loop. Because remember, in your pressure volume loop, that measurement of intrinsic contractility is that maximal elastance line, which the end systolic pressure volume relationship. So the end systolic dimension is a wonderful measure of systolic function itself. It will tell you not only how well the ventricle contracts, but how big the ventricle is, and the ventricle's only going to be able to contract to a certain dimension given its intrinsic contractility. And we know from studies that once the dimension gets greater than 40 millimeter, the prognosis is poorer. So left ventricular dysfunction is number 1, an ejection fraction less than 60 or an end systolic dimension greater than 40. End systolic dimension less than 60% or an end systolic dimension greater than 40 millimeter. Now let's go back to our natural history. Okay, remember we've got the onset of regurgitation, we've got many, many, many years, then at some point in time, incipient left ventricular dysfunction occurs and then symptoms occur. It means here, if there's the onset of symptoms, you're going to operate. They're going to do poorer than if you had operated early, but they'll still do better than if you let them go. Once they have the onset of left ventricular dysfunction, you're going to operate. They're going to do poorer because they've already developed left ventricular dysfunction, but you don't want to let them go. I think what ideally, though, you like to do is you'd like to get to the patient before they develop left ventricular dysfunction and before they develop symptoms, and that's that prophylactic category. In other words, what's the ideal operating time to be able to prevent left ventricular dysfunction in the onset of symptoms? Well, in the past, when we only had mitral valve replacement, we said you would never do it because mitral valve replacement used to have an operative mortality of 8 to 10%, and there's all the problems with the prosthetic mitral valve. But over the years, the surgeons have developed mitral valve repair. And in experienced centers, repair can be done with a greater than 95% success rate, an operative mortality less than 1%, an excellent long-term outcome. So in patients who truly have severe mitral regurgitation, in whom you have a surgeon who can operate with these type of numbers, it's reasonable to operate before the onset of symptoms, before the onset of left ventricular dysfunction, in order to prevent the irreversible consequences that happen with long-standing volume overload. This is Rakesh Suri from our institution, one of his multi-center papers that just came out last year, but it clearly shows that the survival of patients who have early surgery is better than those with medical management as long as they have a repairable valve that can be done with a low operative risk. So it's reasonable to consider operation in asymptomatic mitral regurgitation if it's truly severe MR, if there's a low operative mortality and there's a high chance of successful repair, and that's up to you and your surgeon to talk about it to decide whether or not a valve can be repaired. Which, remember, posterior should be easier than anterior, and you shouldn't have calcium in the annulus and you shouldn't have calcium in the leaflet. What I was just talking about was everything about primary mitral regurgitation. Secondary mitral regurgitation, which is regurgitation due to the ventricle, is a different story. The ventricle is the disease, not the valve. Whether it's due to a dilated cardiomyopathy in which there's stretching of the ventricle, stretching of the chordae in a central jet, or ischemic mitral regurgitation in which there's retraction of the posterior medial papillary muscle. You don't want to operate early on these people because the operation on the mitral valve does nothing in terms of the major problem, which is progressive left ventricular dilatation. So the indication for operation is unclear because it's a disease of the ventricle, but I think the bottom line is you should say that operation should be reserved for severe mitral regurgitation with symptoms unresponsive to treatment of the left ventricle. That means, for instance, if you have a dilated cardiomyopathy with what looks like severe mitral regurgitation, but they have a QRS complex of 160 milliseconds with a left bundle branch block, you're going to do CRT before even considering anything about the mitral regurgitation. You're going to get them on optimal ACE inhibitor and beta blocker and aldosterone therapy before even considering operation for mitral regurgitation. And if they get better, don't operate on the mitral valve because it's a disease of the left ventricle. So that's mitral regurgitation. We went over acute and chronic. Now we're going to go to aortic regurgitation. Again, we're going to talk about acute and chronic. Acute aortic regurgitation is a huge volume imposed on an unprepared left ventricle. There's no time for left ventricular enlargement. You'll have a decrease in stroke volume, a rapid rise in left ventricular dilatation, in diastolic pressure. Tachycardia can't compensate. They'll go into severe heart failure. This is the pressure trace of what you should remember with aortic regurgitation because it shows that the left ventricle has a very rapid rise in diastolic pressure. The aortic pressure has a rapid drop in diastolic pressure. If you take a look at this gradient between the aorta and left ventricle, it gets smaller and smaller very quickly. So you might have very short murmur, or you might have no diastolic murmur at all in severe acute aortic regurgitation. Again, you have to then look at the etiology in aortic regurgitation because it can either be due to a root or a valve. If it's a root and acute, it's probably dissection, you operate right away. If it's a valve, it's probably endocarditis. You're going to treat them with antibiotics, but if they have heart failure, you go in and operate. And remember, the aortic regurgitation may be soft, short, or even absent. And again, surgical intervention is usually indicated. Do not use a balloon pump, because that will increase your afterload and make your regurgitation worse. You can use nitroprusside and anatropes, but do not use pressors, and beta blockers are contraindicated because they'll increase your diastolic filling period and increase the degree of aortic regurgitation. So that's acute. Now next, let's turn to chronic aortic regurgitation. And the etiology of chronic aortic regurgitation, again, can either be intrinsic valvular or problems with the aorta. Juan Bowen gave you a wonderful talk on problems with the aorta. Just remember, any of those aortic root problems can lead to aortic regurgitation. And as far as intrinsic valvular, it's the same etiology as you have for aortic stenosis. The pathophysiology of aortic regurgitation is different from mitral regurgitation because of the load on the left ventricle. Now remember, mitral regurgitation had an increased preload and a decreased afterload. Aortic regurgitation has increased preload because their ventricle is bigger at the onset of contraction. But if you think about it, now you have a huge amount of volume of blood that the ventricle is trying to get through that normal size aortic valve. So your afterload is increased. So the difference between mitral regurgitation and aortic regurgitation is in the afterload, and it's increased in aortic regurgitation and decreased in mitral regurgitation. Now, because your preload is increased and your afterload is increased, it means that after you replace your aortic valve in aortic regurgitation, your ejection fraction doesn't change. Go back to your pressure volume loops. Go back to your Starling and forced tension curves, and you'll see that your myocardial performance doesn't change because you're removing afterload and you're removing preload. So your ejection fraction doesn't change. That's the major difference between the pathophysiology of aortic and mitral regurgitation, and that will help you in timing of operation. Now, clinical presentation, they'll have a long, prolonged asymptomatic interval, may have incipient dyspnea. Kyle again went through the physical findings, but it's that loud diastolic decrescendo murmur. If the jet hits the mitral valve, you may have an Austin-Flint murmur, and you'll probably have a short systolic ejection murmur. The severity of aortic regurgitation, though, is best seen on physical examination or palpated on physical examination by a wide pulse pressure. The murmur needs to be there, but if your pulse pressure is not wide, you probably don't have severe aortic regurgitation. So always measure your blood pressure. You want to make sure that there's a low diastolic pressure, and look for these other signs, the head nodding, the capillary pulsation, and the pistol shot femoral arteries. But aortic regurgitation, on physical examination, it's the finding of the wide pulse pressure that best tells you it's severe aortic regurgitation. Now again, with a bicuspid valve, if there's hypertension with aortic regurgitation, think of coarctation. And if you've got a patient with a coarctation, with a bicuspid aortic valve who comes in with chest pain, think of dissection because of the concomitant aortic aortopathy. Testing again, how does it affect the heart? What causes it? How much is there? Again, use your end diastolic dimension and end systolic dimension for the measurements of how big is the heart. Know whether it's root versus valve. And as far as severity, again, you can use PISA, but probably the couple things that help the most are not only the jet itself, and if it's going to be an eccentric jet, that might mislead you, but the reversal in the descending aorta is a very nice methodology to tell you that there's severe aortic regurgitation if you have reversal in the descending aorta on pulse wave Doppler itself. So remember, the echo color can underestimate and overestimate, and again, if you've got a discrepancy between the echo and your physical findings, cath with a good aortic root injection. So board tidbits in aortic regurgitation and a wide pulse pressure on examination. If the echo says it's only mild because they see a very thin jet, get your aortic root, and if you see a lot of contrast going back, that's severe aortic regurgitation. Now, treadmill testing, there was a lot of literature on exercise mugger. Remember what mugger was, an exercise echo. You don't need it. If you need to get an objective measurement of exercise capacity, you can get a treadmill test, but you don't need to look at the change in ejection fraction with exercise, and that's because we'll talk about the natural history and treatment of aortic regurgitation. Now, as with mitral regurgitation, same type of a scenario. Onset of severe AR, progressive LV dilatation. At some point in time, you'll get left ventricular dysfunction, and then you'll get the onset of symptoms. But the decrease in ejection fraction in aortic regurgitation is different from mitral regurgitation. Because of the increased afterload, increased preload, if your ejection fraction is less than 50%, your prognosis goes down. But if it's greater than 50%, you can still say you have normal systolic function. And remember, that's opposed to mitral regurgitation. So you have a poor outcome with a low ejection fraction, less than 50%, or a huge left ventricle and systolic dimension greater than 50. So you can actually use the 50-50 rule in aortic regurgitation, which then helps you with your treatment. And your treatment is this. Again, turn to medical management, and about 10 to 20 years ago, there were a couple papers saying that you should use vasodilator therapy to slow the progression of aortic regurgitation. But several randomized trials have shown that there is no data to support the use of vasodilator therapy if you do not have hypertension. So you only use vasodilator therapy if you're not going to operate on the patients or they have systemic hypertension, but not indicated for most patients with aortic regurgitation. Now again, timing of operation. And in aortic regurgitation, we're not going to talk about repair because repair can only be done by a couple surgeons in the country. Almost all your patients are going to get valve replacement. So you want to know when to replace their valve. And you replace their valve according to these multiple recommendations in the guidelines. But again, we're going to make this simple. And by making it simple, we're going to go over symptoms and LV dysfunction and LV dilatation. Now, if they have the onset of symptoms, any symptoms, you operate. No doubt about it. So they got severe AR, they get short of breath walking up 2 flights of stairs, you operate. No doubt about it. You operate with left ventricular dysfunction. Now, I said ejection fraction 50% or less, but it's what's normal in your lab. So if your laboratory says your ejection fraction is abnormal, less than 55%, operate less than 55%. But it's whatever is normal in your lab. And remember, you can use the preoperative ejection fraction in aortic regurgitation. Now, the other thing is you don't have to worry about prophylactic because the drop in EF actually occurs before irreversible left ventricular dysfunction due to a concept called preload reserve afterload mismatch. And let me just take you through this because this is important to understand. You've got severe aortic regurgitation. Severe aortic regurgitation leads to left ventricular dilatation. Then because, remember now you've got this big load that you're ejecting against a normal size aorta or aortic valve, you have afterload mismatch. And it's only after that that you get irreversible left ventricular dysfunction. So if you start taking a look at your measurements, the LV dilates, the ejection fraction drops with afterload mismatch. But if you wait until your ejection fraction drops with afterload mismatch and you operate, you've still been able to operate before irreversible left ventricular dysfunction. So there's a lot of numbers that are used throughout according to the multiple studies, but I think something to remember very briefly is that you operate for any symptoms, you operate if your EF is less than 50, you operate if your end systolic dimension is greater than 50. Very, very simple. And the aorta we already talked about with a bicuspid valve. Remember that sometimes you can have very small patients, so you might want to normalize the body surface area, so 25 millimeter per meter squared for AVR, and replacement of aorta is 2.5 centimeter per meter squared. Valvular regurgitation sounds complicated, but actually quite simple. You've got to make sure it's severe. Any symptoms for either aortic or mitral regurgitation, you operate. Any drop in ejection fraction, remember it's 60 for mitral regurgitation, 50 for aortic regurgitation, you operate. Marked dilatation greater than 40 for mitral, greater than 50, you operate. It's actually quite simple, despite all of the multiple papers that have been. A couple words about chronic tricuspid regurgitation. We don't know what to do with it. One thing you should is know that it can either be due to a primary valvular or a secondary abnormality. And what we're seeing more and more of is pacemaker leads causing tricuspid regurgitation. And there's new syndrome now of long-standing atrial fibrillation, especially in older women who then dilate up their annulus and have severe tricuspid regurgitation. Now, we know that because of the tricuspid regurgitation, there's a large volume reflected back to the venous circulation, so you get edema, ascites, and fatigue, and you know about the elevated venous pressure with the large V wave, but the murmur is frequently soft or inaudible. By echocardiography, you can see a large jet. But again, some of the Doppler profiles are very, very good in telling you how much regurgitation there is, because if you have severe TR, you might get a low velocity dagger shape because the right atrium is equilibrating with the right ventricle, and look at your hepatic vein, in which case you see a systolic reversal. Now, when to operate, nobody really knows. We have no or limited data. That's because I put Pat O'Gara in charge of in the valve guidelines of writing up when valve regurgitation in the tricuspid physician should be done. And he actually came up with a very nice set of circumstances. He said, it's severe, your symptoms are unresponsive to diuretics. If it's severe and you're operating on left-sided disease, you should operate on the tricuspid valve. If it's moderate and at the time of left-sided disease, if your annulus is greater than 4 centimeters, you should go ahead and do your annuloplasty. So we've taken you through valvular regurgitation. We've taken you through mitral regurgitation, the presentation, the pathophysiology, the natural history, and the treatment. We've taken you through aortic regurgitation, pathophysiology, natural history, and treatment. And we've said a couple words about tricuspid regurgitation. But let's go back to the cases now. And Steve's going to take over, and we'll see what you can do with your answers.
Okay, let's give him a round of applause. So valve regurgitation is easy, and we're going to show that in our responses to these questions. An active asymptomatic 24-year-old with a heart murmur, bounding carotids, 2/6 systolic ejection murmur, and a 3/6 long diastolic decrescendo murmur. The LV is dilated with an EF of 59%, bicuspid aortic valve with a mean gradient of 12, severe regurgitation, and diastolic dimension of 64 and systolic dimension of 44. Should we replace the valve, do right and left heart cath, nifedipine, or just follow? That's better than beforehand. See, 32%. You doubled.
All right, aortic regurgitation, different from mitral regurgitation. You don't have to worry as much. You can look at that ejection fraction. So for aortic regurgitation, look at the 50-50 rule. If your EF is greater than 50, you're still okay. If your end systolic dimension is less than 50, you're still okay. So, you know, the problem with aortic regurgitation is they're in these young kids. We call them kids when they're 20 and 30 years old now. But they can go for years and years and decades and decades and decades without getting in the problem. So if you take a 24-year-old kid and you put a prosthetic valve in, you know that he's going to need another one in another 15, 20 years, another one in 15, 20 years. So you want to delay as much as possible. And because we know we now have time, because of the load on the ventricle being afterload and preload, we can afford to watch these people. So in this person here, I would continue to watch. His ejection fraction is 59%, his end systolic dimension is 45, and we'll continue to watch him. You bring him back once a year and see how he does.
Okay. A 44-year-old woman with palpitations, times 2 years, but good exercise capacity, 2,000 PACs, normal JVP and carotid, multiple mid-systolic clicks, and a 2/6 late systolic murmur, and diastolic dimension is 48, and systolic is 22, EF is 66, bileaflet mitral valve prolapse with an ERO of 0.5. Should we repair the mitral valve, catheter, vasodilator, or reassure? %, and what did they say beforehand? 60. Okay. So here's the echo, Nish. Bileaflet mitral valve prolapse.
And look at that. It's a large, looks like a large jet going back in the left atrium, doesn't it?
But it's just a flash.
Huh?
It's just a flash.
It's a flash. It only occurs in late systole. And remember, the examination has a late systolic murmur. these patients still have preservation of their chordal apparatus. Their regurgitation is just due to the prolapse itself. And remember, one of the things Sunil's going to talk about tonight is the measurement of the effective orifice area. And this measures an ERO greater than 0.4 centimeters squared, but that's because one assumed that the regurgitation was holosystolic. That's one of the limitations of an ERO measurement. And actually, just to show if you really do, because you have a discrepancy there between what the echo said was severe and what your clinical impression was, CAS just shows a mild degree of mitral regurgitation, which it correlates with your clinical impression. And with just mild mitral regurgitation, you would watch. Now, the other thing to remember is that you always have to look at the size of the left ventricle when you're looking at these regurgitant lesions. And her left ventricular dimension was 48. That's completely normal. You cannot have severe chronic regurgitation with a ventricle that's normal size. You cannot have severe chronic regurgitation with a normal sized left ventricle. So no matter what your numbers on your ERO and regurgitant volumes say, if your ventricle is normal size, beware that this really shouldn't be severe regurgitation. And if it's not severe regurgitation, we're not going to operate on it.
You know, you talked about the role of exercise testing for the stenotic lesions. How do you use exercise testing for your so-called asymptomatic regurgitant patients?
Yeah, so that Steve brought up a very good point, is that many patients, because valve disease is such a chronic process, will say that they're asymptomatic because they've adjusted their lifestyle over years. And if you have any feeling at all when you're interviewing the patient with their history that they might not truly be asymptomatic, an objective measurement of their exercise tolerance is a wonderful thing to do. So you might have this guy who says he can do whatever he wants. The wife is sitting there shaking her head, no. You put him on a treadmill test, and at 50%, the guy poops out and says he can't go on anymore. He truly is symptomatic. And if he's symptomatic, then he requires an operation. So we use exercise testing quite a bit. Actually use O2 testing with that to be able to tell. There's some other groups that use echo Doppler with exercise, and they say, well, that helps to determine further who might need an operation, or look at pulmonary pressure with exercise. We just don't have the long-term data on that to be able to make clinical decisions yet.
Can you say something about when you operate for ischemic MR?
Yeah, I tried not to say very much because we don't know. But the problem with operating for ischemic MR is that it's a disease of the ventricle and not a disease of the valve. I would say that you should do everything you can to treat the ventricle first, which in some cases might be revascularization, and this is where that viable myocardium might come into play. Other cases, it's your beta blocker and ACE inhibitor and aldosterone antagonist. So what you want to do is you want to do everything you can to treat the ventricle first. But if it is severe, and they are severely symptomatic despite optimal medical therapy, then you go in and operate. Now, the nice thing about what's going on now is there are some randomized trials going on to determine whether or not, number one, you do a valve replacement versus a valve repair, and it looks like valve replacement might actually win out. There's also randomized trials going on to say that if you're going in with coronary bypass grafting at the time of the operation, should you leave the mitral regurgitation alone if it's only moderate? So that's a randomized trial going on too. So there's still a lot of questions to be answered, but fortunately we're starting to get some randomized trials to do it, but it's a very, very difficult thing. Yeah. Now, I didn't say anything about the Mitral Clip. The Mitral Clip, I think, again, is going to be a game changer for mitral regurgitation. It's not perfect. It still leaves 2+ mitral regurgitation. But in some of these patients, like Steve talked about, if you have severe regurgitation and they're at very high risk for surgery, the Mitral Clip might be the thing to do.
Okay, a 55-year-old man who's completely asymptomatic, has a 3/6 holosystolic murmur with an early diastolic filling sound. His EF is 58%. His ventricle is 61 in diastole, 41 in systole, flail posterior leaflet, severe MR, and an ERO of 0.6. Should we mitral valve repair, cath, vasodilator, or follow-up? Good. I think it was about 92% beforehand. All right. So, you want to talk about your reasonable to consider?
Yeah, reasonable to consider. Don't have to do it, except, go on to the next slide. Go back to one, go back. This one, the left ventricular systolic dimension is 41 millimeter. So irrespective of whether or not you can repair the valve, this person needs an operation because he's already shown evidence, not this one, the case, keep on going.
Oh, the
keep
case?
on going. He's already shown evidence that
Yeah.
he has left ventricular systolic dysfunction.
Well, and his EF is less than
And
62.
the ejection fraction is less than 60%. So irrespective of whether or not this valve can be repaired, this person needs an operation.
Okay. So, I'm going to summarize.
Yeah, let's summarize. Go to the next slide. So key points on regurgitation. Remember that your Doppler can underestimate or overestimate the severity of regurgitation. You want to get quantitation if at all possible in your laboratory. But if there's a discrepancy between the physical examination and what you get on echo, number-wise, or a discrepancy between what you get on echo number-wise and the size of the left ventricle, you need further information. And even though it's not standard to do left ventriculograms or aortic roots anymore, they are very, very helpful when you have discrepancies. Number two, that I think is incredibly important, is know the load on the left ventricle. Aortic regurgitation will increase preload and increase afterload, so it will not affect the ejection fraction or myocardial performance. Mitral regurgitation will increase preload and decrease afterload, so it will decrease the ejection fraction. And you know what we have to do is, remember that there's a
We're going to do it.
that case that we showed the very first night,
Yeah.
we're going to do again now that they understand this. Remember the one that everybody got wrong?
Yeah.
We'll see
We'll do
what you
that
guys
again.
can do
Yep.
with it. Okay, now, long-standing volume overload can lead to irreversible left ventricular dysfunction even before symptoms. That's why taking care of these patients is a problem. And you have to remember that. So don't wait for symptoms. And even don't wait for left ventricular dysfunction in mitral regurgitation. And then finally, we said this a number of times, you cannot have severe chronic MR or AR with a normal left ventricular size. Intervention for mitral regurgitation, any symptoms, remember 60-40 rule. And if it's repairable and it's severe, consider operation if your surgeon can repair it. Intervention for aortic regurgitation, any symptoms, and remember your 50-50 rule. Now what I've done with that is I've taken a whole lot of recommendations and simplified it down. But actually, if you think about it, if you practice with this type of a simplification, you're going to do very, very well in being your competent cardiologist and taking care of your patients.